So we're just here to take a moment to speak about working in and around the temporomandibular joint, or in and around the jaw. Now, it's anatomically essentially a bilateral joint, so although you have two separate joints, often it acts as one off of the mandible. Now, that's not to say that that's what's going to be going on at each joint, so you still have to treat them separately, but anatomically they're essentially united. Again, like I said, it's essentially a bilateral thing, but it gets a little tricky because if you think about it such as it's one thing off of the mandible, then what ends up happening is you could ignore the reality that there's different things happening at each temporomandibular joint or on either side of the head. Now, your general considerations, at least to identify what's happening with movement at the joint. So we talk about contact for control and control of safety. We also talk about broad contact for multi-point discrimination. So generally speaking, for most people, if you can identify the ear tab, you're going to be in the region of the temporomandibular joint. That doesn't mean you're going to be in a good place to sense it, but if you go ahead and you take essentially the first two fingers and you broadly place them in and around the ear tab, right? So you see the ear tab is right there, and I'm going to cover a general area. So each person's going to be set up a little bit differently, but what we do then is once we're in the area, we can have the patient just open the jaw all the way, good, and then let it close, right? And then what we get is simultaneously, because we're touching both sides, and in this case, we were in a good spot to feel what's actually going on at the joint. What we get is simultaneously information from both sides, so we can see which side is acting slow. So let's just say one side doesn't slide as at the same time, so one side of the jaw moves before the other, so then we have a temporal lag or a lag in time. We can work off of that. Now, that's a good way to sense it. Now, you may not see, but generally speaking, my hands kind of look like that, because what I'm trying to do is also stabilize the head. Now, to work in and around the jaw, we don't always have to go right to the joint itself once we've identified a symmetry of motion. We can go into the soft tissues. Now, there are some people who like to work on the soft tissues in and around the jaw or the temporomandibular joint, specifically the pterygoids, intraorally. Now, in a lot of places, that's not appropriate, either because a practitioner may not necessarily have the legal right to do so, to essentially break the barrier of body wall. There are specific regulations in specific areas. I would say it's probably not even remotely necessary, because essentially when you come anterior, right, so when you come anterior to the mandible itself, you come into the region of the maxilla, right, what you can do, so it's almost like I'm somebody's, grandmother or grandfather kind of pinching cheeks here. So all this tissue will move, and if I slide backwards, right, along the lines and kind of under the maxillary arch, I'm going to run into the anterior border of many soft tissues. So it's not necessarily in this area with muscles mastication that I'm going to be able to pick them apart, but I can get to them, right? So I can get to their anterior border this way. Now, if I just slide on them, right, I can then slide to their posterior border. So all through here, I can work perpendicular to general fiber direction on all of these tissues. So a way to do this is simply to hold kind of a myofascial release. I can also have the patient use an active approach. Now, you want to be careful here because it's going to be quite tender, so what you do is I'm just going to have you open your jaw, good, just till it's comfortable, and then let it close. So you use the concept of to comfort, because if they go any farther, it starts to really, really hurt. But in this situation, you can get relational motion. So I've pinned the anterior border of the muscles of mastication. As the patient moves their jaw, then I get relational motion. So this is pinned and they move the jaw, right? We can use varying holds, right? So that's the anterior border. Like I said, I can come to the posterior border. Sometimes, depending on the patient, the fingers almost end up being too blunt, and we can use a portion of the phalanges, right? We can kind of start to work through here, right? Now, you have to recognize that once you get away from the finger pads, your ability to create two-point discrimination or multi-point discrimination with accuracy is diminished. So this is more of a blunt tool, but you can work through here. So one of the reasons you might do that is sometimes the fit between your hand as a practitioner and the patient's face, or the region that you're working on, isn't appropriate. So you change the shape of your hand, right? You can use the hypothenar eminence. You can do things of that nature. Now, another way to do this, instead of having the patient move their jaw, so in this case, as I draw posterior, what I find is much more tone on the right side. So it's not going to be as visible, but you'll get the general picture. So again, I draw back, what we have the patient do is just turn your head to the left, gentle, and then let go. So again, I've pinned my hand against the anterior border of those muscles, and as he moves, we get the relational motion. So we essentially get the bowing. He doesn't have to move his jaw, so it's a little bit easier on him in most cases when he moves his head, right? So it's almost like the concept of a push-pull, where I can push and pull on the bicep. Right here, I just do the same thing, but the patient moves their own head, or I can move their head for them. Now when I move their head for them, it's just a little bit more likely that my hand will move as well, so we want to be careful with that. But these are just some ideas of working with the soft tissue in and around, very close to the temporomandibular joint, without going intraoral, without going into the mouth. Now when it comes to the actual joint itself, the TMJ, so again, we talked about identifying just broadly, so whether it's 2 fingers or 3 fingers, whatever it happens to be for you, you get into the region of the ear tab and you go ahead and you slide down, and at some point when they open the jaw, you'll feel the joint. You'll feel the joint spaces, the joint line, the joint motion. Now as the patient opens their jaw, right, open all the way, right? Now what ends up happening is whichever side I want to work on it, I'm going to do this on the left side because it'll be a little bit more visible. I'm going to turn his head just so it becomes a little bit more visible. So again, the jaw's open. Now as he closes it, I'll tell him to close it about halfway, so close halfway, and open all the way, and close halfway, and open all the way. Now what ends up happening is as he closes, he pushes back against my fixed point, right, or against a wedge. So as he pushes into this, it actually creates a separational force. So as the jaw comes back, as the mandible comes back onto my finger, it actually creates a wedge. And as he opens and it tips forward, I can slide and create more of a wedge. So open all the way, and it won't be particularly visible, but I can get in a little bit more, and then as he closes, it's the wedging force. As he opens, I can slide in a little bit more, and then let it close all the way. Again, remember, I turned his head just to try to make it a little bit more visible. It's not perfect, but it's a little bit more visible. So we have a way to wedge directly between, or posterior to the top of the mandible, right, to the horn. I'm messing up my anatomical terms, but just right where the mandible and goes into the temporal bone, right? So I have the ability to do that there. What I can also do, let's just say there's a side. Now, sorry, what we can do is if we want to, say if there's one side of the jaw that ends up being, or one side of the mandible that's posterior or anterior, right? What we would generally do is take the posterior side, right? And we can, if you see, I kind of make a hook here. It almost looks like a fish hook, but I can come in behind the angle, depending on the patient. I can come in behind the angle. Now, in this case, it doesn't work for this patient. So often, this is actually what I do, is I can hook behind the angle of the mandible. But in the case of this patient, what I actually have to do is find a different hold. So you'll see me searching. So that doesn't work, then I'll do this, and that doesn't work. And then now what I get is kind of just the finger pads. So as just very gently open, right? Now what happens is as he opens again, I get a bit of a wedge. So I can pull on that, right? So I can, as he opens, there's a force between the two things, so between my hand that stays still. And now if you watch his jaw, right, just as I push, I try to keep his head still. It's not perfect, but you can see I can move his chin in relation to his nose. So if you look at his midline, I can get a movement there, right? Now I try to hold his head still so it's not me just doing that, right? So I can do that. I can hook in behind the angle of the mandible, right? Sometimes I can do it like this. Sometimes I can hook. It just depends on the fit between me and the patient. Another thing that you will see people do is you'll see them, I'll do it on this side, you'll see them come around and hook the chin. You have to be careful when you hook the chin because it's very easy to go down and block the airway or start to make the patient very uncomfortable by putting pressure on the midline of the anterior portion of their neck. So what you can do here, again, you want to make sure that you hold the head steady, but you can get some wiggling of the jaw. So we want to be careful with that, again, because it can be quite forceful. Another thing that we can do, the last thing that we'll show, if you want to be really forceful, you can use this when a patient is seated or when they're on their back. But if this is the posterior side, I've tested it, I've lifted up, I've moved all around the jaw, then what I can very simply do is come in here, come over, I can create a pull this way, right? So I can pull quite simply, or then what happens is if I'm holding here, I can turn the patient's head to the left, or the patient can turn their head to the left, and you can see how if my hand is in the way, the jaw is going to come this way, the mandible is going to come this way. If we're doing that, we have to remember it's quite forceful, it can be quite painful. I will say, just as a general caveat, now that we've gone through some general concepts that utilize a lot of contact and a lot of control, broad contact for multi-point discrimination, again, to find where the TMJ is, to move our hands in different postures so that we can identify and make sure that we fit in the different bony spaces. But then also we want to talk about the fact that anything around the jaw, because we speak quite a bit, we chew, we also make faces, it tends to be quite tender. So you want to be careful, because it's very easy to create a lot of force here, you want to be careful that you don't go straight to creating a lot of force. It can be quite uncomfortable for the patient.